This talk is about cerebral cortical functions. Here are the class objectives. You do not need to read them. We will use them to chart our talk. The talk will be conducted using conversational and question and answer formats. As you can see, the first three statements in this class objective deals with association cortices. Hence, we will talk about them first. The first question is, cerebral interaction with the environment occurs in a non-hierarchical fashion. A true, B false. In this frame, you can see the lateral and inferior mesial surface of the brain. The motor or executive area in front of the central sulcus is shaded magenta. The sensory or perceptual area behind the central sulcus is shaded aqua. As you can see, the perceptual area is larger than the executive area. Somatic interaction with the environment at the cerebral cortical level has a hierarchical arrangement. Interaction is initiated at the primary sensory cortex. The primary sensory cortex captures the information in its most elementary fashion, pass it on to the unimodal association area where these elements are interpreted in the context of the specific sensory modality involved, and then the unimodal association area passes the process information to the multimodal area, also called the heteromodal area or the polymodal area. At the multimodal association cortex, the information is interpreted in the context of other sensory modalities and experiences. Let me give you an example using vision. In this frame, you can see the visual pathway, starting at the retina and ending at the primary visual cortex. The primary visual cortex is equivalent to the primary sensory area of vision. Now I will add two new structures. The structure I am adding represents the unimodal association area. The new structure I'm adding represents the multimodal association area. As you can see, represented in this frame, the right eye is blocked. And I have introduced a half-full glass with a red dot on the right side resting on a piece of wood. At the primary visual cortex, the figure would be represented as it is captured by the retina, upside down, and the left side of the figure on the right side, and the right side of the figure on the left side of the cortex. Then the figure will go to the unimodal association area. There, the figure would be inverted to upright, and the sides will be corrected, but still the person would not know what it is or what to do with it. Then the perception of the image goes to the multimodal association area. There, the information of the image will be analyzed on the basis of past memories and other information from other multimodal areas, and it would be only then that the multimodal association area decide what the figure is and where it is. So it will conclude that it is a half-full glass on a piece of wood. This process is bilateral. So this is the hierarchical arrangement of the sensory cortex. A hierarchical arrangement is also present for the executive area. Cortical interaction with environment starts with the primary motor area creating movement. The primary motor cortex activates the lower motor neuron, which contracts the muscles. The unimodal motor association provides temporal and spatial organization needed to achieve an intended movement. And the multimodal association area decides the purpose of the movement, what movement to make, and in what order it should be made in order to accomplish the task. The motor and somatic systems are interconnected. Some primary sensory areas are directly connected with other primary motor areas. For example, the somatosensory cortex sends connection to the primary motor cortex. But also, the primary motor cortex sends signals to the primary somatosensory cortex. More fibers go from the sensory to the motor than the other way around. The same can be said to occur at the unimodal association cortices and at the multimodal association cortices. One more thing on the subject. It is customary to refer to the unimodal motor area as the premotor cortex or area, and to refer to the multimodal motor association cortex as the prefrontal area. So the answer to this question is false. Next question. Multimodal association areas have traditionally been divided into anterior, posterior, and limbic. A true, B false. The partitioning of the brain into multimodal association areas does not obey the boundaries of the cerebral lobes, nor those created by the specific sensory modalities. This partitioning creates yet another brain map, which we will introduce in the next few minutes. I will start with the lateral surface of the brain. I will first enumerate and locate the primary cortices. The primary motor cortex is present in front of the central sulcus. The primary somatosensory area just behind the central sulcus. The primary auditory area of Hertz, is mostly buried in the transverse temporal gyrus, but a small area can be seen in the superior temporal gyrus, as indicated by the arrow. And the primary visual cortex can be seen at the occipital pole. I have omitted the shading of the area for the primary vestibular cortex, which has two primary sites, one in the anterior region of the superior temporal gyrus, as indicated by the arrow, and the other one at the most anterior area of the interparietal sulcus. I have done so because they are not usually relevant for mental status examination. Now I will enumerate and locate the unimodal association cortices or areas. Starting with the representation of the motor unimodal association cortices. The motor unimodal association cortex includes the premotor area here indicated. In addition, close to the premotor area, we have other motor areas for planning specific muscle group movements. These are, in the dominant hemisphere, the Broca's area, and in the non-dominant hemisphere, at about relatively similar position, the cortical area for speech intonation. The Exner area for writing in the dominant hemisphere, and the area for saccadic eye movements in both hemispheres. In addition to the motor unimodal association area, we have the somatosensory unimodal cortex. This cortex is just behind the primary sensory cortex. The auditory unimodal association area is present in the superior temporal gyrus, and the visual unimodal association area, which occupies a significant portion of the occipital lobe and a significant portion of the temporal lobe. I will now introduce the multimodal association cortices. There are three multimodal association cortices. All three are represented in the dorsolateral surface of the brain. The anterior multimodal association cortex occupies the anterior-most region of the dorsal surface of the frontal lobe, which I have now shadowed. The limbic multimodal association cortex occupies the anterior portion of the temporal lobe, the part of this lobe that is not occupied by the unimodal hearing association area. And the third multimodal association cortex present in the dorsolateral surface is the posterior multimodal association cortex, which occupies part of the occipital, parietal, and temporal cortices. So that is for the lateral surface of the brain. Now let's look at the mesial inferior surface of the brain. In the mesial inferior surface, we find the primary motor cortex, the primary somatosensory cortex, the primary visual cortex, and the primary olfactory cortex, which is the only primary cortex that is not part of the neocortex, but it is part of the paleocortex. In the mesial inferior surface, we also find unimodal association cortices. In this surface, we find the motor unimodal association cortex in front of the primary motor cortex. The unimodal motor association cortex at this location is called the supplementary motor cortex, usually just referred to as the SMA. The A stands for area. The somatosensory unimodal association cortex is found just behind the primary somatosensory area, and the visual unimodal sensory cortex occupies the parietal and part of the occipital lobe. The fourth unimodal association cortex present in the inferior mesial area of the brain is the olfactory unimodal association cortex, which is, as expected, close to the olfactory primary cortex. Only two multimodal association cortices are present in the mesioinferior surface of the brain. The anterior multimodal association cortex, located anterior to the supplementary motor area, anterior to the genu, and inferior to the rostrum of the corpus callosum. The only other multimodal association area that you can see in the mesioinferior surface of the brain is the limbic multimodal association cortex. This cortex is very extensive. Its extension is indicated by the brown shaded area that you can see in this frame. So the answer to this question is true. Next question. Another name for the anterior multimodal association cortex is the prefrontal cortex. A true, B false. This frame presents three views of the brain. The anterior multimodal association area is shadowed. The function of the anterior multimodal association cortex include high-order concept formation, memory, learning, planning, and personality. The anterior multimodal association center is also called the prefrontal cortex. So the answer to this question is A. Next question. The limbic multimodal association cortex encompasses the same areas as the limbic cortex. A true, B false. The area of the brain shaded in this frame represents the limbic multimodal association cortex. The function of this cortex includes linking emotion with sensory input, learning, and memory. The limbic multimodal association cortex occupies the anterior part of the temporal lobe in the lateral surface of the brain and the temporal mesial surface. Also, in the mesial surface, it occupies about the posterior two-thirds of the cingulate gyrus, extending anteriorly to the posterior edge of the prefrontal cortex. In this new frame, we are also looking at the same view of the brain. The area shaded is the limbic lobe, which, as you can see, through having some areas in common with the limbic multimodal association area, it has a different distribution. The areas adjudicated to the limbic lobe are the parahippocampal gyrus, the surface of the uncus, the isthmus of the cingulate gyrus, the cingulate gyrus, all the way to the subcallosal area. So the answer to this question is B. Next question. One of the functions of the posterior multimodal association cortex is to bind sensory input into a coherent whole. A true, B false. Posterior multimodal association area, by virtue of its location, is especially suitable to receive and integrate information from the somatosensory unimodal cortex, the hearing unimodal association cortex, and the visual unimodal association cortex. So the answer to this question is A. Next question. The area anterior to the primary motor cortex is occupied by the multimodal association cortex. A true, B false. As we have already mentioned, the area occupied by the anterior multimodal association cortex is also called the prefrontal cortex. The prefrontal cortex occupies three frontal regions, as we have also mentioned before. These areas are adjacent to each other, thus greatly interconnected. The first of this area I will mention is the one found in the lateral surface of the brain. If we draw a line tracing the central sulcus and another one tracing the lateral sulcus, we find the frontal lobe anterior to the central sulcus and above the lateral sulcus. Just anterior to the central sulcus, we find the primary motor cortex. Anterior to the primary motor cortex, in the upper part, we find the premotor cortex. Anterior to it, we find the eye center for saccadic eye movements. Below, you find Broca's area in the dominant hemisphere, and just above, in the dominant hemisphere also, you will find the Exner area. It is anterior to these areas that you find the anterior multimodal association area, also called the frontal dorsolateral multimodal association area. The second component of the prefrontal cortex is found in the inferior surface of the brain. As you can see in this specimen, I am pointing to the cerebellum and now to the brainstem. This new arrow points to the cut and removal of the anterior segment of the right temporal lobe. The shadowed area is the orbitofrontal multimodal association area. The third area of the prefrontal cortex is found in the mesial surface of the brain. I have now added the central sulcus, and anterior to it you have the primary motor cortex. Anterior to the primary motor cortex you find the supplementary motor area. And I have now color red the cingulate gyrus. The anterior part of this gyrus and the mesial frontal region constitute the frontal ventromedial multimodal association cortex. This frame shows the prefrontal area as mapped by Brodmann. You do not need to know the numbers of these areas, but occasionally while reading some anatomy textbooks they may be mentioned. So I want you to know that they exist. Anyway, one thing is easy to remember. In the lateral, the medial, and the inferior surface of the brain, 10 is at the tip. So the answer to this question is false. The first question of this section is, the main connections of the frontal dorsolateral multimodal association area includes the mediodorsal or dorsomedial thalamic nucleus. A true, B false. This is the lateral view of the brain. In it you can see the frontal or anterior multimodal dorsolateral association area. It is connected with all multimodal association cortices with other prefrontal cortices in the ipsilateral and contralateral hemispheres, but it has no direct connection with primary cortices of any kind, even with the primary motor cortex. In addition to these cortical connections, the frontal dorsolateral association cortex has indirect but very significant connection with the cerebellum. The pathway to the cerebellum involves the inferior olive, but perhaps the most important subcortical connection of the frontal dorsolateral unimodal association area is the thalamus. As you can see, I have introduced in this frame a representation of the thalamus. The cells in the mediodorsal group have many connections, mainly with the frontodorsal lateral association area, but also to a lesser extent with other prefrontal cortices. So the answer to this question is A. The main subcortical connections of the frontomedial association area are with the hypothalamus and the brainstem. A true, B false. In this frame, you can see the frontomesial multimodal association area. It is interconnected with the other two ipsilateral frontal multimodal association cortices, and it's also connected with the homologous contralateral region. Other important connections are with the hypothalamus, the brainstem, and the amygdala. These connections are not direct connections, but they are very robust connections. So the answer to this question is true. Next question. The main subcortical connections of the orbitofrontal multimodal association area includes the primary visual cortex. A true, B false. The orbitofrontal multimodal association area is most often referred to as the orbitofrontal association area. It is interconnected with the other two ipsilateral frontal multimodal association cortices and with its contralateral interpart. Other important connections are with the hypothalamus, with the brainstem, and with the amygdala. The amygdala connections with the orbitofrontal association are functionally very robust. So the answer to this question is B, false. Next question. The amygdala and the hippocampal formation are far from each other. A, true, B, false. This is a representation of the lateral surface of the brain. Here I have superimposed a parasitical cut specimen stain with neuronal stain in order to point out the amygdala and the hippocampal formation. The line I have just placed represent the margins of a coronal cut going from the vertex to the anterior region of the temporal lobe. I have now removed the brain outside the lines and I am starting to turn the section as such to show the coronal view and point out to you the amygdala and the hippocampal formations. So the answer to this question is false. Next question. The amygdala communicates with the frontal multimodal association cortex. A, true, B, false. This is the same parasitical view you were looking at before. The lines are in the area of the brain that was previously cut in the process of answering the last question. I will now move this line anteriorly and do the same rotation as before, so we can see a more anterior coronal cut of the temporal lobe with a better view of the amygdala. The amygdala reaches the medial frontal multimodal association cortex and the orbitofrontal association cortex directly or going through the hypothalamus by way of the stria terminalis, and from the hypothalamus fibers go to the frontal association cortex. So the answer to this question is true. Next question. The mammillary bodies are involved in reward behavior and goal-directed behavior. A, true, B, false. This is the mesial view of the brain. You can identify the brainstem, the cerebellum, the diencephalon, and a mammillary body. The mammillary bodies, which are protuberance on the ventral surface of the hypothalamus, contain the mammillary nuclei. The brainstem is divided into midbrain, pons, and medulla. The area I have just shaded is called the tegmentum. I have now placed a square confining the center region of the mesial view of the brain and remove all labels except for the mammillary body and the tegmentum. Now I have enlarged it so we can better see these two regions. And now I have traced the mammilotegmental tract. This tract is very important for reward behavior and goal-directed behavior. So the answer to this question is true. The three most important tracts of the mammillary bodies are the mammillothalamic tract, the fornix, and the mammilotegmental tract. A, true, B, false. This is a mesial view of the brain with a deeper dissection of the mammillary region. You can see the right mammillary body, the fornix, the region of the anterior thalamic nucleus. I am now indicating the mammillothalamic tract or bundle of Vic-Zaire, of whom I will tell you more in a few minutes. I have now traced and labeled the mammillotegmental tract, the third important tract of the mammillary bodies. So the answer to this question is A. Next question. The Papez circuit involved the hippocampus. A true, B false. The Papez circuit deals with memory and emotions. It combines the subjective, autonomic, and somatic elements. The number to remember when thinking of the Papez circuit is 5. To start with, the name Papez has 5 letters, 5 connecting pathways, and 5 relay stations. The first leg of this circuit goes from the hippocampal formation to the mammillary bodies. I will first point out the location of the hippocampal formation. Here I have represented the brain. The black line is an attempt to portray it uncut. Now the upper half of the left brain is removed. You can see the hippocampal formation and the mammillary body, of which actually you see only one. The pathway between these structures is the fornix. This way, the hippocampal formation fibers connect with the ipsilateral and contralateral mammillary bodies by the right and left fornices exchanging fibers at the commissure of the fornix. The second leg connects the mammillary body with the anterior thalamic nucleus. This connection is made by way of the mammillothalamic tract represented by the interrupted lines in this frame. I will now take a little detour to tell you one thing about the man who studied this tract thoroughly. His name was Félix Vic-Zaire, and he lived in the times of the French Revolution and died of natural causes. That tells you that he was a very smart man. The third leg of the circuit goes from the anterior thalamic nucleus to the cingulate gyrus. The connection between the anterior thalamic nucleus and the cingulate gyrus is made by the thalamo-cingulate fibers. The fourth leg of the circuit goes from the cingulate gyrus to the parahippocampal region. Here I am indicating the cingulate gyrus, and now the parahippocampal region, especially the area of the entorhinal cortex. This connection is established by the cingulum. This view allows a better look at this leg of the circuit. You can see the parahippocampal region and adjacent cortices which I have shaded, and also the cingulate gyrus. But you cannot see the connection between the cingulate gyrus and the parahippocampal region because this tract travels deep in the cingulate gyrus. You can see this tract. This tract is called the cingulum, as we have just mentioned. The fifth leg of the circuit goes from the parahippocampal region, especially from the entorhinal area, to the hippocampal formation, especially to the cells in the dentate nucleus. Here I am pointing to the parahippocampal region and here to the hippocampal formation. The connection between the parahippocampal region and the hippocampal formation is made by the perforant pathway, which I have drawn in this frame and now labeled. So the answer to this question is true. After talking about association cortices, we will talk about neglect, agnosia, and apraxia. We will start with a question. Right hemiparesis is more frequent than left hemiparesis in patients with hemibody neglect. A true, B false. Neglect can be defined as a lack of attention to events and actions in the personal and extrapersonal space. Hence, it can be considered a spatial planning disorder. Our awareness of a space around us for all sensory modality is represented in the posterior parietal region of the lateral surfaces of each hemisphere. I have in this frame made the posterior parietal region involved with self-space orientation of the left hemisphere yellow and the one in the right hemisphere aqua. In this figure of a man looking forward with the brain exposed, I have marked the left side yellow and the right side aqua. Now I have added the yellow area in the left posterior parietal region. This area is in charge of surveying the right side of the personal and extrapersonal space, as you can see in this frame. That is the right spatial perception field. When it comes to the spatial perception field perceived by the right posterior parietal region, the spatial perception field, as you can see, is bilateral. Hence, the composite of the spatial perceptional fields, as you can see in this frame, is surveyed differently. The right spatial perceptional field is surveyed by the left and the right posterior parietal regions, whereas the left spatial perceptional field is surveyed only by the right posterior parietal region. So a patient with a left posterior parietal region lesion will lose the right spatial perceptional field recognized by the left posterior parietal region, but it will not have a great impact in the overall span of the perceptual field because the right posterior parietal region sees both. But if the lesion expands anteriorly enough to involve the primary cortex, the patient will present with a right hemiparesis. On the other hand, a patient with a right posterior parietal lesion will lose the left spatial hemifield perception. Hence, contralateral neglect will be present. And if the lesion expands anteriorly, a left hemiparesis will occur. So the answer to this question is B. Next question. A patient capable of identifying the seat and the pedals in a bicycle but not the bicycle has A. prosopagnosia, B. anosognosia, C. anosodiaphoria, D. simultaneous agnosis. In this question, we have 4 possible answers. I will go through each of these possibilities and then we will choose the right one together at the end. The first possibility is prosopagnosia, which we will define as the inability to recognize a familiar person in a picture or in flesh. Patients with this condition can describe appearance of the person but are unable to identify the person. Let's say we show a patient with prosopagnosia this picture and ask, who is it? The patient may say mother. The answer is obviously incorrect. Then, when we ask to describe what the patient sees, the patient appropriately recognizes the individual features and can describe them and make sound conclusions, even to the point of changing their original answer, like in this case to father. Then you put the picture away and ask, who was the first president of the United States? The patient will answer correctly. What is the anatomical area tested by asking the patient to recognize a face? If all other sensory modalities work well and semantic memory is normal. The area being evaluated is the bilateral fusiform gyra, also known as the temporo-occipital gyra, here shown in this frame. The second possible answer is anosognosia, a term that we will define in the next frame. It means not being able to recognize an illness. As you can see in this frame, a patient with hemiparesis is asked, how are you? And his response is fine. If you insist, he continues to say that he's fine, and even wonders why you are thinking that he's not. And if you direct him to the abnormal arm, he still thinks it is fine or denies it is his. The anatomical area most often involved in patients with anosognosia is the right posterior parietal area. The third possible answer in the question is anosodiaphoria. In patients so affected, when you ask, how are you doing? The patient will tell you, I'm okay. If you ask about a specific action you see the patient is having trouble with, he or she will say that it is okay and minimize or brush aside the limitation. But the patient will recognize that there is a deficit. If you ask, can you use your right hand? The answer will be no, but I do fine with it. Anosodiaphoria has occurred in patients with right hemisphere lesions at multiple sites. Lesions producing anosodiaphoria has been reported mainly in the right parietal region, but also in the temporal lobe. The fourth answer is simultagnosia is a condition where the affected individual sees specific details of a complex scene but fails to grasp the overall meaning of the image. Simultagnosia usually occurs with bilateral lesions in the occipitoparietal regions, such as bilateral infarcts in the posterior watershed areas. So the answer to this question is D. Next question. Ideational apraxia refers to the loss of ability to order a series of acts to achieve a goal. A true, B false. Praxia, defined as achievement of a learned activity, includes walking and talking, since both are learned motor activities. Yet, most neurologists I know define apraxia as a disorder of learned skill upper limb movements and tool use in the absence of elementary motor deficit, sensory deficit, and general cognitive impairment, such as inattention to commands, object recognition deficit, or poor oral comprehension. Yet, even among most neurologists I know, what is a learned skill movement and what constitutes a tool is capriciously decided. For the purpose of this discussion, based on the book I am showing you in this frame, we will consider three types of apraxia. Ideomotor apraxia, which will be divided in three subtypes: parietal, sympathetic, and callosal. The typical example of a patient with ideomotor apraxia is a person that can describe how to use a tool, such as a comb, but when asked to use the tool, is unable to perform the task. The different types correspond to the different areas of the brain involved in producing the ideomotor apraxia. The second type of apraxia is kinetic. Is defined as the inability to make fine, precise movements with the limb. The distinction between kinetic limb apraxia and some ideomotor apraxia is not clear in many instances. And the third type, ideational. Ideational apraxia implies the loss of ability to order a series of acts to achieve a goal. The classic example is the patient that has always made perfect sandwiches using these ingredients that you see in this frame, and all of a sudden he prepares a sandwich in this fashion with the bread inside the tomatoes. This type of apraxia is usually seen with diffuse brain disease such as dementia. So the answer to this question is true. Now that we have concluded with this element, we will approach definition of aphasia and dysarthria and the different types of aphasia. We will do so with a question. A patient's speech problem characterized by poor comprehension, non-fluent speech, but good repetition, voice production, and articulation has A. Dysarthria, B. Semantic dementia, C. Transcortical motor aphasia, D. Transcortical mixed aphasia. This chart offers a broad look at the speech problems. Deafness, as you all know, is a problem with hearing. Dysphonia with voice production. Patients with dysphonia speak very softly. The first step in their evaluation is to make them cough. A bovine cough indicates vocal cord problems related to vagal nerve dysfunction. A good cough should be followed by requesting the patient to sustain a sound. If they are able to do so, the cause of the dysphonia is a local laryngeal problem. If the sound fatigues, myasthenia gravis is the most likely cause. After dysphonia, we will consider another speech problem, dysarthria. Dysarthria means poorly formed words. The workup is by far more complicated than the workup of dysphonia. A good approach is to evaluate the rhythm of a speech. If it is normal and the speech is nasal, the patient is likely to have palatal palsy due to vagal nerve pathology if local nasal pathology is ruled out. If a speech is distorted and the worst pronounced letters are T and L, the patient has a tongue palsy, likely due to hypoglossal nerve problems. If the speech is distorted and the worst pronounced letters are B and M, the patient has a facial palsy due to cranial nerve 7 involvement. These three types of pathology relates to lower motor neuron disease. On the other hand, if the patient's rhythm is abnormal, the easiest to recognize pathology is when it is due to cerebral dysfunction. Patients with this condition talk like drunk. The speech is slurred and disjointed. The main rhythmic characteristic of extrapyramidal speech is monotony. The speech tends to fade out during long sentences. This is often seen in patients with Parkinson's disease. Labored and slow speech is characteristic of a spastic speech usually seen in patients with cerebral strokes in the lower region of the precentral gyrus or the fibers emanating from it. The lips in these patients are held almost closed when talking. Having talked about dysarthria, we will talk about aphasia. Aphasia is a dominant hemisphere problem, the left hemisphere being dominant in about all right-handed people and most left-handed people. For this discussion, we will assume the left hemisphere as dominant. Aphasia can be chronic, developing slowly in a progressive fashion. These types of aphasia are called primary progressive aphasia and are the presenting findings in patients with a type of dementia called frontotemporal dementia. This condition can only be diagnosed in the absence of an alternative explanation for the clinical findings. The primary progressive aphasia occurred in different variants. The semantic variant, also called semantic dementia, involves both temporal lobes, the left more than the right. Semantic dementia is characterized by fluent speech, impaired object knowledge, word and sentence repetition is normal. In logopenic variant, the damage is usually exclusive in the left hemisphere, involving the middle and posterior temporal lobes and extending to the parietal lobe, as you see in this frame. As in semantic variety, patients with this condition also have fluent speech. The main feature of the logopenic variant is that patients with this condition, by the time they hear the third word in a sentence, they have forgotten the first one. In the non-fluent or agrammatical variety, the damage primarily involves the left perisylvian region. Speech is non-fluent. Repetition is affected. The term of atypical variant of primary progressive aphasia is used for those progressive aphasia that do not fit any of the prior variants. Acute aphasia is usually due to vascular disease or tumors. A good way to have a simple understanding of the most common types of acute aphasia is to construct the diagram you see in this frame. Get a sheet of paper and copy it. It is important that you notice that it has only 3 parameters: comprehension, fluency, and repetition. If comprehension is good, but speech is not fluent and repetition is poor, the patient has the aphasia described by this man, Paul Broca. This type of aphasia is called expressive aphasia, and it is due to involvement of the frontal triangular and opercular part. These parts are located in the inferior frontal gyrus, and they correspond to Brodmann area 45 and 44. Now let's go back to the chart to introduce a new type of aphasia. In this type of aphasia, comprehension is poor, repetition is poor, but speech is fluent. This aphasia bears the name of the man you see introduced in this frame, Karl Wernicke. It is called receptive aphasia. It is due to involvement of the Wernicke's area that corresponds to the posterior part of Brodmann's area 22. It is important to remember that words spoken, read, or written, in order to be comprehended or repeated, must go through the Wernicke's area. Hence, in Wernicke's aphasia, reading and writing is also affected. Now, let's go back to the diagram. If comprehension is good, speech is fluent, but repetition is poor, the patient has a conduction problem. This is called conduction aphasia, and it is due to damage to the arcuate fibers. This damage usually occurs at the end of the sylvian fissure in the subcortical area corresponding to the supramarginal gyrus. Now let's go back to the diagram. If the patient has poor comprehension, fluent speech, and good repetition, the patient has a transcortical sensory aphasia. In transcortical sensory aphasia, the cortical areas supposed to store information about the meaning of words are disconnected from the Wernicke's area. Repetition is good, because Broca's area, Wernicke's area, and the arcuate fascicle are in good working conditions. Now let's go back to the diagram. If comprehension and repetition are good, but speech is not fluent, the patient has a transcortical motor problem. This type of aphasia is called transcortical motor aphasia. It represents a disconnection of Broca's area from the area that stores the memories required for grammar and intonation of speech. Now let's go back to the diagram for one last time. A patient that has poor comprehension and speech is not fluent, but repetition is good, has transcortical mixed aphasia. Transcortical mixed aphasia results from the receptive and expressive areas of the brain related to speech being deprived of input from other cortical areas. So the answer to this question is D. So we have finished talking about aphasia and related conditions, and I will go on to make a few comments about memory and the lack of it. Memory is divided in immediate recall, working memory, and long-term memory. Long-term memory is further divided into explicit or declarative memory and implicit memory. Explicit or declarative memory is always dependent on mental effort. Explicit or declarative memory is divided into semantic, which is the memory of learned facts as you do in a school, and episodic, which is the memory of events that have occurred through your life. Episodic memory is the most affected in patients with Alzheimer's disease. Implicit memory implies memory requiring little in the case of procedural or no effort in the case of non-procedural. Non-procedural memory is further divided into priming, sensitization, habituation, somatic, and emotional memory. Regarding the classification of amnesia, at this point, I will mention that anterograde amnesia refers to an inability to make new memories. Retrograde amnesia to an inability to recall previously recalled or expected to be recalled memories. Thank you very much for your attention.